have our infectious disease chief, Dr. Robert Gullberg, here to speak on where are we with bacterial resistance. You know, looking at his bio, it would probably take the whole hour to list all of his accomplishments that this man has done, but I'll give you a quick synopsis. Undergrad was at Northwestern University. He went to med school at U of I Medical School, and then did residency at Evanston Hospital via Northwestern University, and then a fellowship in infectious diseases. He's worked here since 1986, correct? Internal medicine and infectious disease. He's taught multiple students, over 200 varying types of medical and physician assistant students in the past, I think, 18 years. He has done many different travels abroad. Again, he's also taught at Marquette University, Roslyn University, Medical College of Wisconsin, Carroll University, Concordia University. He was named top physician in the Milwaukee area twice, last time being in 2016. He was named the top physician for ID specialty in Milwaukee area for 2015. He's had multiple publications and journals. He's written several textbooks. He has an online blog, Dr. Bob Gullberg, on YouTube that you should really check out, where he has education that's free. It's great. So I could go on and on, but please welcome Dr. Robert Gullberg.
Hello. There we go. Is it working? Hello? Perfect. All right, great to be here to talk about a problem that's dear to our hearts. I'm sure all of you out there. What's the farthest we're coming from for this talk? Amy and Shelley are here. Great. River Falls. Okay. Okay. 4 hours. Wow. That's great. So the most important thing on this is this got a pointer? There it is. Heroes in infectious disease. These are my heroes. Dennis Mackey. You all know Dennis? So he's a good friend. He's a good friend. He comes to our fall conference here in November. And he's not coming this year, but he's come many times. He's a great individual, writes all the textbooks. John Fair and Rob Murphy were my mentors at Northwestern in Chicago years ago. Wonderful people. Rob is now the worldwide leader in AIDS and HIV treatment in Africa. So he's very active in that regard. So it's hard to believe that I was working here in India years ago. These were our typical, rooms we would be working in. With 20 people in a room. Weren't really thinking about bacterial resistance too much back in those days. And then at Northwestern, this was our typical, in fact, our ICU in the VA had like 12 beds right in a row, just with a curtain. And again, we weren't thinking about resistance too much. When I was infectious disease fellow, in 1986, Dr. Petersdorf, who wrote the textbook of internal medicine, he was also an infectious disease specialist, said this: I cannot conceive the need for 309 more infectious disease experts. That was how many fellowship spots there were in the United States, unless they spend their time culturing each other. Okay, so needless to say, I would say about a third of our consults, and we see about 1,000 consults a year here, about a third of them are related to bacterial resistance. So the question is can we win this battle against bacterial infection? Here, infection control is over here, and here we're dealing with a lot of difficult things to deal with. We've got agricultural issues, we've got long-term care facilities, we've got poor antibiotic stewardship, We have poor immunity. That is, we've got more people with cancer, more people with kidney failure, cirrhosis, and we've got an aging population. We've got these multi-drug resistant organisms, which we're obviously going to talk about today, and we've got hospitals that are using more and more devices. This is an escalating issue, which leads to, our problems with nosocomial infections. In my opinion, right now, we're barely keeping our heads above water. We have shrinking budgets. I never would have thought this would have happened 30 years ago. Severely producing shortages in our men and women power to do the work that's required. It's hard enough to track our nosocomial issues, but budgets seem to be winning over common sense. I don't see the problem getting easier. This was some of my slides come from Dr. Mackey. This is Dr. Mackey's office back in 2007, and what he said in a lecture I heard, he thought this was going to be his office in 2017. That just isn't going to happen. My guess is all of you working in your different systems are dealing with the shrinking healthcare budget, where you're having to do the work of two people instead of one person. You're fighting burnout. So, couple of interesting facts about agriculture. You all know how bacteria, end up getting into our guts, into the guts of animals, and how we kind of mix through time, these bacteria. So the issue is that antibiotic use in farming is amazing. It's 80% of antibiotics sold today in the U.S. are used in animals to prevent infection and to promote growth. So antibiotic resistance has been shown to be a huge issue in the intestinal flora of both farm animals and farmers. And it's a bigger problem than we talk about, okay? Or the U.S. government talks about. Our long-term care facilities are big problems, okay? We've got 15,000 long-term care facilities in the U.S., 4 million people there. Half of them have dementia, okay? And 5 to 25% of them have an indwelling medical device. It often takes 2 people, staff members, to handle people, more contact. 5% of these people likely have an MDRO. So long-term care facilities are not going away. Dr. Mackey talks a lot about this, as well as Dr. Bartlett, who's at Hopkins. 50% of the time, antibiotics are prescribed when either not needed or for an incorrect duration or dosage. So this is where, we're really getting big on antibiotic stewardship. Been going on for about 10 years, but really we're focusing on just stopping the paradigm of treating people too long. 50% of all hospital patients receive antibiotics during their hospital stay. I was just telling my students yesterday, about 30% of people on IV antibiotics get diarrhea when they're in the hospital. And of course, we're obliged to check for C. diff. We order C. diff testing, then automatically they're put in isolation, which is tough, but it's the facts. So the bacteria we've got, this was just talking a little about how resistance gets started. Obviously, we kill a lot of good bacteria and bad bacteria, but resistance occurs on the basis of our antibiotic utilization. And the resistance is spread bacteria to bacteria, as you know, through plasmids. I'm far from a molecular biologist, but I will review some of that in the next few minutes. we forget that the immunity of our patients is so poor. I mean, I have to emphasize this to you. So here's a patient that I had, 55 years old, HIV patient with hepatitis B, hepatitis C, and hepatitis D. Plus, he was on dialysis. So he was not a very compliant individual. He ended up with a MRSA infection of his left arm fistula and MRSA bacteremia. So remember, when you have a dialysis patient or somebody with kidney failure, there's 8 problems that they have with their immune system. A lot of it is about their polymorphonuclear function, their decreased inflammatory response, their inability to activate properly the cytokine and complement cascades. And then, of course, they're all vasculopaths. They have numerous vascular catheters in place that fail, get clotted, and they end up with multiple infections related to that. Then we deal with liver failure patients, okay? The typical ICU patient that we've got is somebody comes in, they're an alcoholic with liver cirrhosis. This particular patient was drinking a pint of vodka for about 30 years. Comes in, she's got Klebsiella pneumonia, otherwise known as Friedlander's pneumonia. Septic shock, has a prolonged hospital stay of 12 days. And of course, we're charged by the government to get these people cured quickly. Well, when you've got cirrhosis of the liver, you got big time problems with complement, killer cells, toll-like receptors, and PRRs. So all these are very important parts of the immune system. Point being that we're behind the 8 ball from the beginning with taking care of a lot of our patients. These are not people with normal immune systems. So as antibiotics have been discovered back in around 1940, and decade by decade, more antibiotics have been discovered. The sad thing is that once an antibiotic's been discovered, about 10 years later, resistance is already occurring. So since 2 million people a year in the US are infected with bacteria that are resistant to a given antibiotic, and 23,000 of these individuals die, it's incumbent upon us to continue to wake up about this. So interestingly, vancomycin's been around since 1972, but did you know in the last 5 years, last 10 years, vancomycin use is up 32% because of MRSA. And then as we use more vancomycin, then we get more VRE, okay? Because that's been directly linked. Because even though imipenem was discovered over 30 years ago, penem use is up 37% in the last 10 years because of ESBL. So now we've got carbapenemase bacteria, which we'll talk about. Our cephalosporins, our 5th-generation cephalosporins really get hit. The beta-lactam ring is the focus of the bacteria. The amide bond right here is what gets hammered at the cephalosporin level, whether it be Ancef or Rocephin or ceftazidime. So our antibiotics have all these targets inside the bacterial cell wall, and yes, the bacteria are smart enough to develop efflux mechanisms, target modification, programs that they program themselves with, and inactivated enzymes, ESBLs, et cetera. We'll talk about those in a little more detail. Our clean antibiotics, the quinolones, okay, 1st-generation nalidixic acid back in the day, 1960, became resistant very quickly and was removed from circulation. And we waited till the 80s for ciprofloxacin, and the leofloxacin, the L isomer of ofloxacin, came out then. And then, of course, 4th generation, the only one that's active now is moxifloxacin. But these quinolones are getting beat up now also. Fortunately, levofloxacin still has good activity against the pneumococcus, but we're having a lot of issues with resistance because of overuse by antibiotics. So classically, the quinolones had been used for gram-negative coverage, aerobic rod coverage, but we've had all these agents that have been available to us to kill gram-negative aerobic rod infections caused by the classic bugs. Now we've got a few agents out like Zerbaxa that are helping with the more resistant organisms. So they come out with ceftazidime, avibactam for $800 a day to kill these ESBL and KPC organisms. We've got Zerbaxa, and then we've got a new one called Vabomore. But you can see that the antibiotic pipeline has dried out. When I came out in the mid-'80s, we had a ton of new antibiotics, and antibiotic utilization has increased, but the development of new antibiotics is decreasing. I'll discuss that in more detail at the end of the lecture. So Fleming discovered by accident penicillin in the mid-40s, but look what he says about resistance. The microbes are educated to resist penicillin, and a host of penicillin-fast organisms is bred out. In such cases, the thoughtless person playing with penicillin is morally responsible for the death of the man who finally succumbs to infection with the penicillin-resistant organism. I hope this evil can be averted. So that was 70 years ago. So one of my jobs as an infectious disease specialist, and I'm sure I'm beating the proverbial drum with you folks, is that fever is not a sign of ceftriaxone deficiency. So one of the things we teach the students is when people have a fever or a fever of unknown origin, it's not always an infection. And if it's an infection, if you don't have a source for the infection and they're not in septic shock, you don't need to place people on antibiotics right away, okay? But there's a mentality out there from physicians and mid-level providers sometimes that they have to do something to put people on antibiotics. That's just not the case. So as we teach about staph infections, this is important to understand the difference between Staph aureus and Staph epidermidis, understanding that depending on your location, if you're out in the middle of nowhere in the country somewhere beautiful, your MRSA percent MRSA strains may be low, relatively speaking. However, if you're in a more urban area or you're in an area where there's maybe you're at a tertiary medical center where there's sicker patients, you may have a very high rate of MRSA. Here, we range between 40% and 50% in that range. As you know, the prosthetic devices love Staph epidermidis, and the resistance to for Staph epi is always around 50% to beta-lactam antibiotics. So one of the things I teach the students is dividing your gram-negative rods into two tribes, tribe 1 and tribe 2. Tribe 1 classically are our most popular and common bugs that we see cause infection clinically, E. coli, Proteus, and Klebsiella. 98% of our bacteria are not ESBL and CRE, so most of the time we get by. Tribe 2 are the more resistant gram-negative aerobes, and we call these the space organisms. Serratia, Pseudomonas, Alcaligenes, Citrobacter, and Enterobacter. Classically, these bacteria are resistant to first-generation cephalosporins and usually sensitive to third or fourth generation cephalosporins. As we talk about resistance, I go to Dr. Mackey's, this is a Dr. Mackey slide to kind of just look at, historically, all the bacteria, the major pathogens have had issues with resistance. Today, we're not talking about gonorrhea and, Haemophilus influenza or MCAT, or even HSV. HSV has there's a resistance to acyclovir. I am going to share a case of MTB with you at the end of the lecture of a very difficult case I had here just a couple years ago that required me networking with the Mayo Clinic as well as with Barb Seabrook down in Texas. Pneumococcus we're not going to talk about today. We're going to obviously focus on Staph aureus and gram-negative rods and enterococcus. But now we're even seeing resistance to CMV, and of course, certain Candida species are extremely resistant. I just heard we had a problem with resistant ectoparasites. We had a problem with resistant lice. I mean, holy mackerel, that's incredible. So what is a MDRO? So these are multi-drug resistant organisms that have developed resistance to one or more classes of antibiotics, okay? So as I said, they're primarily bacteria, but it may be related to a virus, a fungi, or a parasite. Let's talk a little about MRSA and see what's going on in the state of Wisconsin with MRSA. So when did MRSA start becoming a problem? Well, Staph aureus has been around for ages. In fact, when we would treat staph infections in India, and I was between India and Nepal in a hospital, we had the ability to do microbiology there. Our Staph aureus were sensitive to penicillin. But with more antibiotic use, penicillin resistance developed quickly in the 1950s. Methicillin was discovered about 1960, and along with nafcillin and oxacillin later, the semi-synthetic penicillins, dicloxacillin, of course, is the oral agent. By the 1970s, certainly methicillin resistance was occurring. As MRSA occurred, we started using vancomycin for it. You can see what happened with vancomycin use in the 1990s. Not only did we get more VRE, but now in 1997, we got Visa strains. And then in 2002, and that's already 15 years ago, we've had Versa strains, vancomycin-resistant Staph aureus. Very sad to see this. Very difficult problems to treat. So one of the things about MRSA, here's a 16-year-old varsity or a football player, comes in, had 3 episodes of MRSA infection, and they've all occurred on the right leg, okay? A player on the team that shares obviously the same workout area, the same locker room, probably gets into the whirlpool at times, the same whirlpool. MRSA is cultured from this leg. Most people, when they get a MRSA infection in the leg, will develop an abscess with the cellulitis. The typical, I've had a spider bite. That's what people come in. They come in the ER and they say they've had a spider bite. They didn't see the spider, but to have something this ugly, they think they had a spider bite when they didn't. They have a MRSA infection. PVL, or Pantin-Valentine leukocidin toxin, digs deep and really can destroy tissue significantly. When we look at a sensitivity pattern for MRSA, most important thing, of course, is to look at that oxacillin resistance. But interestingly, this particular strain was also resistant to clindamycin, the macrolides, sensitive to tetracycline, Bacterium, linezolid, and rifampin. The creamy pus of Staph aureus is golden yellow. It has no odor whatsoever. Okay? If there's odor with purulent drainage, it may be a staph infection, but there's something else that's going on with it. MRSA is mediated by PBP2A, encoded by the MEK-A gene. And there's numerous clones now of MRSA all over, circling all over the world. And MRSA is certainly related to the antibiotic pressure of cephalosporin use and fluoroquinolone use in the last 20 years. Computer keys are colonized with MRSA in your hospital, and it's not just the head of the stethoscope, it's the ear tips that are colonized with MRSA. You want to make sure you clean your ear tips regularly. The bug gets around. In the lung, MRSA causes an overwhelming infection. Very fluffy infiltrates with respiratory failure, and then can just eat the lung for lunch. These are called pneumatoceles caused by MRSA, and very overwhelming infection. And certainly, I don't do pediatrics, but in children, it's really really terrible. So all these problems in diabetics, in immunosuppressed patients who are being treated for their rheumatoid disease, osteomyelitis, sepsis in patients over 65. Patients are having influenza problems. Watch for staph after their influenza. All these drugs are used for MRSA infections. They've never been studied head to head, which one's better than the other. They're all effective. Similarly, intravenous antibiotics, vanco's been the workhorse for years. Ceftaroline is our 5th generation cephalosporin that's quite effective. Linezolid's good, except long-term utilization is difficult because of bone marrow suppression. There's another one out, Tedizolid, which has less bone marrow suppression. Of course, we use Dapto for people with MRSA bacteremia in the setting of endocarditis. Well, how about in the state of Wisconsin? Looks pretty promising. And this is just recent literature that's been published. The rate of MRSA bacteremia is 51% lower in the state of Wisconsin than the national baseline. And that's a good thing. If we look at, this is an interesting graph that graphs out community-acquired MRSA versus hospital-acquired MRSA. And what they've shown is that hospital-acquired MRSA infections tend to peak more in the wintertime. And then as summertime comes, there tends to be a rise in the community-acquired MRSA infections, which tend to be more skin infections, whereas the hospital-acquired MRSA tend to be more related to or cause pneumonias. This was some literature published by the UCLA people a couple of years ago, and they had an interesting perspective on screening and colonization. What their study showed is that screening patients for MRSA colonization, isolating those who were positive, resulted in 3 times as many patients in isolation and no decrease in nosocomial transmission. So there is some very dynamic dialogue going on right now as to the efficacy of isolating people with MRSA. This study the Cleveland Clinic looked at doing another approach to infection control with MRSA, saying, hey, surveillance is very important, especially going in the intensive care unit, targeting that group of people, decolonizing these people with chlorhexidine bathing and intranasal Bactriban, which obviously showed a declining acquisition of Staph aureus and healthcare-associated MRSA infections in their ICU. So VRE, which is basically Enterococcus faecalis, or excuse me, usually most of them are Enterococcus faecium. This is an organism that is primarily found in stool and very high cause of bacteremia, urinary tract infections, and intra-abdominal infections. Does not frequently cause skin infection or pulmonary problems. What's interesting about this bug is that it doesn't secrete exotoxins or produce any superantigens. But boy, when it's in the bloodstream, it's absolutely it's a terrible organism to contend with. In Europe, they showed an increase in VRE related to the use of glycopeptides as food additive for growth promotion in their animals. So resistance trends are worsening. VRE is also on the rise. VRE, though, when it's found in the stool, it's usually asymptomatic. Usually people are fine with it. They're living in symbiosis with it. But if you're immune suppressed, especially if you have a transplant, watch out, because if you get bacteremic from it, there's a high rate of endocarditis. And like I said, it can be frequently an organism that causes UTIs, especially its proximity in the perineum. VRE treatments usually with linezolid or tadalafil and then daptomycin. I don't have as much experience with these agents, and tigecycline we don't use. The organism has been found to survive on countertops for a week, okay? And obviously, studies have showed some improvement with environmental cleaning, which decreases the rate of VRE acquisition. People can stay colonized with VRE for a year after a positive culture. So it can hang out for quite a while. The way we're going to get rid of VRE is probably through antibiotic stewardship, with decreasing the use of vancomycin and third-generation cephalosporins and anti-anaerobic drugs. But there's no effective method for decolonization. People ask me, well, how many ESBLs do we get here? Based on last year's antibiogram, we had 54 isolates of ESBLs, extended spectrum beta-lactamases, out of 2,620 isolates. So about 2% of our gram-negative aerobes were ESBLs. I'm not going to get into the molecular biology of it, other than to tell you that these enzymes that are produced by the bacteria are pretty sophisticated. Most commonly, they hydrolyze the amide bond of the beta-lactam ring. I showed you that early on in the lecture. TEM, SHIV1, CTXM, OXA are common enzymes produced by these bacteria. Once we have a ESBL infection, we generally treat it with carbapenems. There's no need to do combination therapy. If it's sensitive, obviously, to a piperacillin and tazobactam, we'll use that, or cefepime. I'll talk a little about fosfomycin in a second. So there's a higher mortality rate and morbidity rate with ESBL infections, longer duration of care, and increased cost of treatment. Very important to do proper surveillance on these patients. Remove the focus of infection if possible, especially if it's a contaminated bronchoscope or if it's a central line, and then doing proper isolation and contact precautions. Hand hygiene is obviously very helpful. Who are the best hand washers in your institution? Usually it's the respiratory therapist, physicians tend to be the worst hand washers, but hopefully the nurses are high as well. So here's a case that we see. So here's a 50-year-old male with profound mental retardation of brain injury at birth, has a PEG and a suprapubic catheter, battles recurrent serious UTI. So he's on antibiotics a lot, and this is the typical scenario of somebody who gets an ESBL E. coli. Sensitivity pattern for an ESBL for this particular organism: resistant to quinolones, mostly resistant to trimethyl-sulfa, sensitive to the penoms, resistant to cephalosporins, and resistant somewhat to piperacillin tazobactam, sensitive to the aminoglycosides. So we're constantly looking at our sensitivity patterns. To see gram-negative rods that are developing resistance to the penoms is pretty darn scary. We're seeing increased Klebsiella species, otherwise known as the KPC organism. You can see it's really rampant on the northeast coast. But, you know, with time, I think it's going to be moving this direction. Klebsiella is a bad enough pathogen because it's encapsulated, and it's a nasty, causes a nasty, nasty pneumonia. With it being resistant now to, some of the strains being resistant to carbapenems, it's pretty ugly. You look at the worldwide problem with KPCs, not only the US, but it's also China, and it's parts of Europe, parts of Eastern Europe also, and South America. Obviously, a lot of it's in other places as well, but we don't have enough data to you know, really get everything we need, obviously from Africa. So these penoms that we've got here are a wasted time with the carbapenemase organisms, and the emergence of these resistance, this resistant problem is really bad. So what do we do when we've got a patient with us? Here's a patient we had who had a VAP. This was several years ago. Had a Klebsiella pneumonia organism that was a carbapenemase organism. We ended up treating the patient with colistin. How does colistin work, and what are its potential side effects? We don't like to use the drug because it's somewhat toxic. It is bactericidal. It binds to lipopolysaccharides in the outer cell membrane of the gram-negative bacteria, causing death. But we got to watch for nephrotoxicity, neurotoxicity with vertigo, and we'll use it primarily as a inhalation. I see a lot of people from nursing homes as well as people who have chronic Foley's in from neurogenic bladder, whether they've had a stroke, whether they're paralyzed from a previous spinal cord injury. And you can see, fortunately, we've got a drug called fosfomycin, which is a sachet, very effective for CRE patients. You see, this is just comparing a CRE versus a non-CRE coli, 87.5% sensitive to fosfomycin. Klebsiella, 90% sensitive. So that's a good thing. Again, not to belabor the molecular biology, because these are so complicated, these enzymes that are produced. I don't have the brain power to go through it. But they are becoming more and more well defined. Let's not forget about Acinetobacter baumannii, which is a bad bug in itself. A lot of problem with Acinetobacter. I didn't realize this in Iraq and Afghanistan with a lot of the injuries from the from the bombing that was going on. They had a big problem with post-op infections from Acinetobacter, which is actually not a gram-negative rod. It's kind of a gram-negative diplococci or coccobacillus organism, but it causes some major problems, not only in our country at times, but also around the world. The organism tends to be sensitive to sulbactam, so we will frequently put these people on Unison up front empirically. Pseudomonas, hot tub folliculitis is easy to treat. Usually that's not going to be an issue. Periungual infections are a problem, but when Pseudomonas becomes invasive, like it can in blood vessels in the lung, it can really do some dastardly things. Since it loves water, it loves the hospital. That's kind of what I say. It loves sinks, loves toilets, loves the mops, loves the cleaning supplies, loves ventilators, and it loves endoscopes. So it's perfect nosocomial pathogen. And once it's prevalent, it produces a grapey, slimy drainage that smells like grapes. And it's very toxic. It produces exotoxin A, which causes significant tissue damage, especially in the lung. And it causes a lot of our VAPs. Here's a burn patient I took care of a couple years ago, just helped with our wound care nursing. You can see this green, this green drainage typical of Pseudomonas. But this Pseudomonas that was invasive here, and Pseudomonas does cause a lot of problems in burn patients. You can see the resistance here, resistant to Cipro, resistant to the cephalosporins, including cefepime, resistant to aminoglycosides, resistant to piperacillin, sensitive to aztreonam, tobramycin, and meropenem. So this was a typical ESBL. Enterobacter is more of a, when we see resistance with Enterobacter, it's more of an AMP-C problem. We call it AMP-C. We try to shy away from using cephalosporins with patients with Enterobacter because they can develop resistance to cephalosporins very quickly. So even though it may initially show sensitivity, we try to be very careful with using a cephalosporin. Now, one thing that we've done at our institution, and if you haven't, we would recommend it for you. We are using something called the Verigene for blood cultures for our gram-negative rods. It basically gives us whether there's any CTX, IMP, KPCs, MDMs, OXAs, or VIM DNA detected. It basically works in about 2 or 3 hours. Good, really helpful for us to detect a nasty organism. For our staff gram-positive cocci in blood cultures, we're obviously using a polymerase chain reaction methodology to get really quick results on DNA testing to help us know that whether it's just a coag-negative staphylococci or whether it's a MRSA or a MISA, DNA. This is what the Verigene looks like. We have a plan, action plan, whatever we get on the organism. Jim Davis works with me. He's our guru, antibiotic guru. Pharmacist is just a wonderful partner. We work together. We have a really good notification system. We've already got our drugs of choice picked out in case we get one of these voracious organisms. And we have even alternative drugs to pick. So our MDROs flourish in our nosocomial environment. And I think it's prudent in my last 10 minutes here to review this problem. This is one of my favorite slides of Dr. Mackey's. So this is I'm sure is ICU in Madison. When our patients are like this in our ICUs and they're, you know, have 4 or 5 lines in them, plus a Foley, plus they've had surgery, it's a wonder that they don't get sick with a nosocomial pathogen. Our problem is that we've got understaffing going on. And I know we have issues with getting staffed properly. I'm sure you may also. There's an increased risk for nosocomial infection. This has been documented for the last over 30 years. I don't know how that can be fixed except kind of a paradigm shift. This was just looked at recently with the state of Wisconsin is doing some good things, looking at CLABSIs, CAUTIs, MRSA bacteremias, SSIs, whether it be hysterectomy, colon surgery, C. diff infections, all of our problems. You can see how nice Wisconsin's doing, the state of Wisconsin as a state relative to the rest of the United States. So congratulations on that, because I know you're a big part of it. So these nosocomial infections add a lot of days to our hospitalizations. Our organisms we've got resistance developing in all these organisms, and it's going to continue. I present this case as an example of one of our typical consults. John Lucky Man is 55. He comes in for an elective laparoscopic cholecystectomy. During the procedure, the gallbladder tears, bile is leaked, bile peritonitis is diagnosed. Postoperatively, he develops urinary retention, a Foley catheter is placed. Then, a post-op ileus prompts an NG placement. During the NG placement, he vomits and aspirates, causes an aspiration pneumonia. 2 days later, his abdominal wound leaks bile and purulent drainage is noted. His temperature spikes to 103 degrees. Blood cultures grow ESBL E. coli. So where is the likely source of infection? So, I mean, literally, no matter how smart you are, you can't figure it out. I mean, it could be the new pneumonia, could be the Foley catheter, could be the surgical wound infection. So if we compare VAPS to HAPS, okay, MRSA is alive and well. Pseudomonas is alive and well. And we're even seeing Stenotrophomonas multifilia, especially in VAPS and Acinetobacter infections. Actually, Dr. Mackey did some of these original studies on colonization of pathogenic bacteria in patients that are in the hospital. Once you've been in the hospital for 4 days, your organisms in your mouth get recolonized, so you're no longer going to be carrying, strep viridans and Peptostreptococci and Gamella organisms. You're going to be probably carrying gram-negative bacilli and maybe MISA or MRSA. Understand that there's a difference between VAP, HCAP, and VAP. These healthcare-associated pneumonias are serious too. So these are patients that are not hospitalized, like our HAPs are. These are patients that are in long-term care centers, and they're maybe having access to health care regularly. Maybe they're going to the infusion center for chemotherapy. Maybe they're dialysis patients. As we go from CAP, which is our community-acquired pneumonias, and that's primarily going to be pneumococcus, H. flu, MCAT, Legionella, Mycoplasma, and Chlamydia. As we go from those organisms to HAP and VAP, and VAP's going to cause 80% of your hospital-acquired pneumonias, that's when we're going to have more and more problems with our multiple drug-resistant organisms. If you get a HCAP It's going to add 11 days to your hospital course, 25% mortality. Obviously, we've got bundles going on to help treat and prevent HCAP, but nobody's perfect, are they? Now, when we go to line infections, this is typical. So here's a 40-year-old female comes into the ER with hypotension and shock. She's got an SVT with a heart rate of 200. An emergent jugular venous catheter is placed. And what type of infection can come from this line? So indeed, it's sad to see somebody come in for that and end up with a central line infection. We see several infections that can come from this. Exit site infections are usually the easiest to deal with. Somebody has a tunnel infection, that's trouble. The line's got to come out. Septic thrombophlebitis and septic emboli of the lung, of course, are very serious and require prolonged treatment and removal of the line. Staph coag negative is going to cause most of these bloodstream infections. But Staph aureus, that's MRSA and MRSA, are close behind. If you get a yeast in the blood from a line, that's trouble. So not only do you have to pull the line, but you have to treat these patients with IV antifungal agents for a minimum of 7 days. And there's the enterococcus again. So even though it doesn't frequently cause skin infection, it can colonize the catheter and cause bacteremia. Pseudomonas and other gram-negatives like Klebsiella are there as well. So another good case, here's a 65-year-old professional football player, has a total hip arthroplasty. Postoperatively, has a Foley catheter in for 4 days. That's a mistake. Develops fever to 101 with purulent-looking urine. Urine shows 25 white cells per high power field and grows MRSA. Place the patient on vancomycin. Remove the Foley as soon as possible. Okay? Otherwise, you're going to, this is going to wreak havoc in your patients. You're going to have potentially serious infections. You're going to add to the hospitalization and morbidity and potential mortality to the patient. Here's a smoker with peripheral vascular disease who had an iliofemoral bypass. Unfortunately, the wound dehisces, drainage is cultured, grafts exposed, cultures out staph epi, and we've got a surgical wound infection. This adds 7 days to the hospitalization. There's the graft right there. Here's somebody with a sternal wound infection, which obviously adds a lot of extra morbidity and trouble to the extended hospitalization. So we see the MRSA here. We're going to see resistant gram-negative rods, as we've talked about. And the other thing to remember about surgical wound infections is they may smolder for 1 to 2 weeks after the patient's discharge. So they first present in the doctor's office rather than in the hospital right afterwards. So you gotta check for that. I think I'll skip this serratia infection because I did want to talk to you about this case I had recently. So here's a very sharp 32-year-old female. She immigrated from India 5 years previously. She presents with hemoptysis and cavitary pneumonia, weight loss, and malaise for 4 months. Here's her chest x-ray, the classic reactivation tuberculosis, okay? Now, what makes her special is that her organism was resistant to INH, rifampin, PZA, and ethambutol. So we normally, when we treat tuberculosis, of course, we normally treat people up front with these 4 different agents. after a lot of work with Barb Seaforth and Tim Axamet at Mayo, we settled on moxifloxacin, para-aminosalicylic acid, cycloserine, amikacin, and linezolid. She was treated for 2 years, and we cured her. Fortunately, she required, a lot of ongoing testing, and the Kenosha Health Department was really very helpful in that situation. So MDR-TB is TB that's resistant to INH and rifampin. Extreme MDR-TB is resistant not only to INH and rifampin, but also to the quinolones. Now look at the MDR-TB in the world, okay? And you can see, again, India, watch out, and then China is tough. Of course, we don't get the statistics from Russia, but there's a lot of resistant tuberculosis in the world relative to the U.S. In the U.S., most of the resistant TB is in California, Alaska, in the Indian population, Texas, Florida, and New York, where the high urban centers are. So in this lecture, I've looked at the tug of war that we've got against bacteria. We've talked about the problem we have with agriculture in our United States. We've talked a little about nursing home facilities and long-term care facilities being a source of ESBLs. We've looked at the fact that there is a problem with antibiotic stewardship. If you're not doing antibiotic stewardship, you better start doing it wherever you're at. Things we don't control or we can't control is the aging population, that we're seeing more and more cancer. We're suppressing people's immune system. So by definition, they're going to have problems with serious infections. And we've got dialysis patients and patients drinking their Miller Lights, which is going to keep going forever. So it's a brutal predicament that you are all in right now, because I don't see it getting better. We're putting more and more devices in our patients. And I think the U.S. government is expecting us to just solve this problem very easily and do a better job and work more hours to, take care of it. Tough issue. I think the future is going to be related to non-antibiotic inhibitors of bacterial growth. I think it's going to be a lot of these different ways of doing it. We're going to use hemoperfusion. We're going to use gene therapy. We're going to use lytic bacteriophages. We're going to use monoclonal antibodies. We're going to get better vaccines. We're going to use liposomal-based toxin inhibitors, and we're going to use tolerizing approaches to allow hosts to tolerate bacterial pathogens. It's not going to be in our generation, but the future has got to change from what we're doing, because what we're doing, I don't know if we're going in the right direction. My favorite author is Sir Arthur Conan Doyle. I love Sherlock Holmes books. You should read them. Teaches you how to think didactically and algorithmically. A man or a woman should keep his little brain attic stocked with all the furniture that he is likely to use, and the rest he can put away in the lumber room of his library, where he can get at it if he wants it. There's only so much you can keep in your brain. You're going to spend a lot of time in the library. Thank you.